webinar, which gives 3 SAMHSA leaders the opportunity to go through a number of significant topics from their point of view. This will be followed by questions, I'm sure, and we will get those questions to you very shortly with answers. And then I figure let's give our colleagues at SAMHSA a month in order to provide those responses. We did release the recording of the first webinar, which we did last Wednesday on March the 20th. And so you should have received that this morning. So with that, we think that these regulations are very forward-thinking. I have said that in writing and certainly in a recent press release. They have been thoughtfully executed, and I know the implementation date is April the 2nd, and a full compliance will come in October 2nd. So our colleagues at SAMHSA will tell you more of that. So of the 3 speakers, the first is Dr. Ingvild Olsen, then to be followed by Dr. Rob Ballio, and then finally Dr. Patty Giuliani, all from CSAT. Obviously, Dr. Olsen is the director of CSAT, and Rob Ballio, who I believe has been the chief responsible party in constructing these regs, and then Dr. Patty Giuliani, the director for the Office of Pharmacologic Therapies. All 3 have terrific experience. They have, in my opinion, done a masterful job in crafting these regulations. So we think they're excellent. And now we'll start with Dr. Ingvild Olsen.
Great. Thank you so much, Mark. And thank you all for joining this either afternoon, morning, wherever you may be. I am joining you here from Baltimore City, where it is gray and rainy today and fairly cold. But it is such a pleasure to be able to really speak with everyone around these proposed rules and dive a little bit deeper into some of the clinical and particularly medical areas as well. So I think we are just waiting for the slides to come up. And I know that I saw already that there were a couple questions in the chat from folks who may have joined us last week when we went through some of the more administrative aspects of the rule. You will probably see some repetition today. I think repetition is always helpful, particularly when we're talking about incredibly substantive changes as we have made in this final rule. We also mentioned last week, and I'll say it again, that this is just the beginning. We know that, as Mark mentioned, the effective date is next Tuesday, which means that is the first date on which OTPs can take advantage of some of these changes. We also know that there is a significant amount of other pieces that need to fall into place. Both, there are state regulations, there are also OTP policies and procedures that need to be looked at, the accreditation bodies we've been working with, and will continue to do so. And that's why the compliance date of October 2nd is really the place and the date on which we are kind of aiming to really have everyone come into compliance with these rules. Ultimately, as you can see on this slide, the goal here is really to enhance the care being provided and the standards of services provided in OTPs, improve collaboration with partner services, and really facilitate access to medications for opioid disorder. Because, as we know, we are continuing to lose over 100,000 people from overdose every year. And most of that is driven by illicitly manufactured fentanyl. And given the life-saving properties of medications like methadone and buprenorphine, that really being able to provide people with those services. If you can go back, please. Let's go back one. Sorry. So so being able to provide people with those services in a way that also engages them really, you know, makes the treatment in OTPs accessible, easily accessible, and services that people really want to, you know, be able to take advantage of and stay with. I think is kind of one of the goals here. If you could just go back one slide. Oh, but maybe we're having some difficulties with that. Okay. So I just wanted to highlight, because I do think that, you know, as we've mentioned last week as well, that really the idea here and the vision is that we are really proposing a culture change in OTPs and in the way that care and service delivery is managed in OTPs. You know, I think, and this is clearly a generalization, but, you know, for many years, particularly, you know, kind of early on, that the culture that much of society had in terms of how to address substance use disorders, including opiate use disorder, was really based in not necessarily a strengths-based or really recovery oriented, or, you know, harm reduction really kind of was not part of the general lexicon within treatment, the treatment field. And that what was much more common was people, you know, kind of taking and individuals experiencing a more punitive approach. And that's really kind of what we are trying to move away from as a field, as you know, the understanding of the science of addiction and the science and evidence of what actually works and how we more on the strengths-based and positive approaches, and that fostering trust and recovery in a patient-centered environment is really where we are then able to engage individuals, meet them where they are, help them make positive change in an environment that also puts them at the center. So that patient-centered care approach with a shared decision-making approach that also happens and that is really the standard of care in much of other chronic disease condition management, because ultimately it is the patient that has to then engage with that, take the medication that is being prescribed to them, whether that is for diabetes or hypertension or opiate use disorder, and that the needs of individuals changes, and it can change, you know, from day to day, it can change week to week, month to month, year to year, so that really being responsive and flexible in terms of the OTP services that are being provided for something that is also grounded in evidence. We know that approaches such as motivational interviewing and cognitive behavioral therapy and peer supports, like all the kind of the supportive services that people may need to really help them achieve their goals, is something that is also kind of part and parcel of the roles as we'll talk about. I think the other piece to this is that we know that the medications that are being prescribed in OTPs are being ordered rather and dispensed in OTPs. They're control medications. And so that also then does include a need for practitioners to really be able to use their clinical judgment and weighing risks and benefits, again, with the patient, with a lot of communication with patients, so that those risks and benefits, whether it is at the starting dose of the medication, you know, titration schedules, take-home dose decisions, etc., that really is then also part and parcel of kind of what is underlying some of the approaches that we've included. And what that means is acknowledging the skill and patient-centered understanding of you know, treating practitioners, so that they are, we know that there are lots of very skilled and excellent nurse practitioners, physician's assistants, other physicians who practice in OTPs. And so really being able to incorporate and include that expertise in just about all of the different aspects of services that happen in OTPs as well. And so kind of making that really official within the new rules. And so what that all means is, between kind of the patient-centered care, shared practitioner-patient decision-making approaches, using a practitioner's clinical judgment, and the training and the skill that they have, and in an environment that is also responsive and flexible, and that is grounded in evidence-based practice, and that really then incorporates non-stigmatizing language, non-stigmatizing approaches, that also then ends up promoting medications for opioid use disorder as a very viable treatment for a chronic medical condition that then ultimately we hope really also helps to reduce the stigma, not only related to opioid addiction and opioid use disorder, but also the medications, because many of us, I think, have had that experience of unfortunately hearing from people, patients, and others about the stigma related to methadone and buprenorphine, but particularly related to methadone. And so we have, hopefully, the vision is that, with really kind of making these changes, that we can then also help reduce that stigma and really save people's lives, help them kind of on that path to recovery, whatever that might look like for that individual, and in the time frame that actually is then along the process of chronic disease management that we know can sometimes take quite a long period of time. So next slide, please. Slides forward. Okay, thank you. So I'm going to just kind of go through this very quickly because we're going to do a deeper dive into each of these areas. So, but just as a reminder that the final rule does make permanent some of the flexibilities for the provision of take-homes. It revises the criteria for take-home doses, really, again, making that change from what has been kind of a rule-based to one that is based in clinical judgment, using that risk-benefits framework that we apply to lots of other medical decision-making, and then making the taking the two components of medications as well as other counseling services and other services, kind of not making those necessarily tied the way that they sometimes have been. And so removing that medication access as being contingent on participation in counseling services, but understanding that people can still benefit and really often want to engage in other services to really help them reach their goals. So that really making sure that the OTP is still offering that comprehensive set of services, such that that people can then engage in them on an individualized basis, and so that that care plan actually becomes really truly individualized. I think the other kind of major highlight is this incorporation of harm reduction and recovery principles, and we'll kind of go through that a little bit more. We know that the harm reduction, treatment, and recovery continuum is incredibly important now that we have a very dangerous drug supply that people are experiencing, and so making sure that we can do whatever we can in order to really help save those lives. Next slide, please. And are you able to move the slide forward one? So I think, okay, so with that, I'm going to turn it over to Dr. Bailey to really kind of start to take us a little bit deeper into many of these different areas.
Thank you so much, Dr. Olson, and hello everyone, and welcome. It's incredibly Wonderful and heartening to have you here today. We see there's so many people, and this is such an interest in this revised rule. And creation of this revised rule really represents a really close collaboration among people here and also across SAMHSA. And that's entirely appropriate because this rule is complex and it required different perspectives and different voices in order to bring it to life. Perhaps if we transition to the next slide while I introduce myself. My name is Rob Bailey. I'm a primary care physician and senior advisor here at SAMHSA CSAT. And it's my privilege today to really take a deeper dive into some of the clinical aspects of the revised rule before handing over to Dr. Juliana. And principally, one of the key elements of the revised rule was to really acknowledge the profound skill and understanding that practitioners working in OTPs bring to patient care. This is important because as practitioners, you interact with the multidisciplinary team and the individual and have a really important knowledge of how that individual is operating, where they are in their stage of change and how they're responding to treatment. And that should be reflected in how the individual receives care. Certainly, there are elements of the revised rule that haven't changed, and that is that the medical director must be a physician, and the medical director is responsible for all medical and behavioural health services performed by the OTP. But what has changed, and what has changed in the last 23 years, is that we now have different categories of practitioner who are skilled and brilliant at providing care, and this is our NPs and PAs. And they are now, we're allowed under state law to manage all forms of MOUD provided by the OTP. In addition to that, we recognise that people coming into care are often coming from different environments. They often come at different times of the day, and that it's really important that that screening exam, wherever it be done, provided it be done within a certain time period, be recognised. This allows people to enter care in a timely manner. It allows them, with the screening exam, to start receiving treatment. And so both the screening examination and full examination do have to be completed by a licensed practitioner. But if the licensed practitioner is not affiliated with the OTP, the screening exam really should be completed no more than 7 days prior to admission. This ensures that the information is, of course, up to date, and that when it is transmitted to the OTP, the results of that screening exam be read and assessed by the practitioner working in the OTP. And of course, transmission of the examination results and any associated screening must be done in a secure HIPAA-compliant manner. If we could start transitioning to the next slide, please. And perhaps, sorry, if we could go back to slide 10. Thank you. As Dr. Olsen mentioned, the revised rule really makes permanent those flexibilities issued during the COVID-19 pandemic, principally the use of telehealth for the initiation of buprenorphine. But in looking at the evidence and the results of how that flexibility played out over the course of the pandemic, we've also realized that initiation of methadone using audiovisual technology should be permissible. And this is because there is a difference in methadone and buprenorphine. Sorry, we could go back again. Thank you. There is a difference in these two medications, and that seeing the individual who could potentially be starting on methadone is important because of the risk of sleepiness and other associated side effects. So ensuring that eyes-on approach is taken, but using or promoting telehealth technology is an important way of expanding access to care. It allows individuals to engage with OTP services remotely as well, so that overcomes some geographic disparities in access. The screening and assessment can be completed via telehealth as documented in the rule. And certainly that there is that time period caveat, so 7 days for the screening exam. And we'll talk more about the other assessments in due course. But if we could move to the next slide, please. Thank you. A really important aspect of the revised rule is to expand admission to the OTP. And Certainly, removing the 1-year opioid use disorder requirement for adults and the 2 unsuccessful attempts at withdrawal for patients less than 18 years of age is a really important way for individuals to now receive access to services. It removes some restrictions and barriers. When it comes to admitting someone, the individual has to meet criteria for a moderate to severe opioid use disorder or have an active moderate to severe opioid use disorder that could be in remission or is at high risk for recurrence or overdose. The "or" clauses there provide many avenues through which the individual can enter care. So certainly that needs to be documented in the patient's chart, and then they can undergo screening and commence treatment. Again, that raises the point as to when the individual can commence treatment. And we recognize that the screening exam is an important aspect to that because it confirms the diagnosis, it confirms suitability for treatment. And to bring people into care, that initial screening is going to be the first point. And after that has been completed, the individual can then start treatment with medications for opioid use disorder. The physical and behavioral health assessment should be completed within 14 days following admission. And then there are requirements for periodic completion thereafter. And certainly the physical and behavioral health assessment is more comprehensive in nature and requires different elements. But that is to ensure patient safety. It's to ensure that the individual is receiving and offered any services that they might need. And really, it's an opportunity to make sure that the OTP is aligning to where the individual is in their course of recovery. Of course, when it comes to admitting an individual to treatment, it is, with any chronic medical condition, really important that the individual voluntarily chooses that they enter treatment. All the relevant facts concerning the use of methadone, buprenorphine, or naltrexone need to be provided to the patient, spoken through, and the opportunity to pose and answer questions needs to be there as well. And of course, that then plays into the informed consent aspect of treatment, which of course must be obtained and signed and documented in the chart. Next slide, please. When it comes to starting medication, we do receive a lot of questions about the so-called starting dose. And certainly we have seen an increase in the so-called starting dose within the revised regulations. And the total dose for the first day is now up to 50 milligrams, unless the practitioner determines that a higher dose was clinically indicated based on their own understanding of the patient and the patient's response to treatment. If more than 50 milligrams is needed, then that can be documented in the chart. And that's all that has to happen. Certainly, the individual should be monitored. Their response to treatment should be recorded. And if more than 50 milligrams is needed, that just gets documented and medication be prescribed. Ordered. If a patient is, as part of their screening, expected to undergo lab testing, we realize that a barrier to accessing care is a patient's potential refusal to undergo lab testing, and that should not preclude them from access to medications. We want people to receive treatment. And so if a patient's refusal to undergo lab testing is not dangerous to them receiving treatment, then that can be waived. Certainly, if lab testing is thought to be important, then that needs to be a discussion with the individual. The reasons for the importance, the medical necessity, and documenting that in the patient's chart is going to be really important as well. However, where lab testing is considered to be standard and not necessarily going to change the course of treatment, the patient has every right to refuse. That is autonomy, and that is consistent with the management of a chronic condition. Certainly, some patients in the community do undergo lab testing with their primary care practitioner, for example. And if those labs are, I think, within 7 days old, then it's perfectly okay to include them with the screening. And so that we recognize that there are other sources or locations whereby the individual may undergo lab testing. Next slide, please. when it comes to the provision of take-home doses of methadone, we take that provision from COVID-19 and make it permanent within the revised rule. Certainly, decisions around dispensing take-home doses of medication really should be determined by the OTP practitioner or the medical director. And this is clinical decision making. And moving away from the 8-point criteria, we've developed a risk-benefit analysis that should occur to really highlight that this is a safety issue. This is one that should be discussed with the individual, and that it is clinical decision making that, if documented in the patient's chart, is perfectly acceptable and appropriate. The elements of the risk analysis should consider an absence of active substance use disorders or other physical or behavioral health conditions that increase the risk of patient harm as it relates to the potential for overdose or the ability to function safely. Certainly and this may not be applicable early in treatment, but the regularity of attendance for supervised administration of medications, the absence of any behavioral health issues that could endanger the patient or the public, knowledge of any diversion, and thinking about the safe transportation and storage of the medication once it leaves the OTP environment. And then, of course, there's that flexibility for the medical director or practitioner to consider other factors known to them in their trusting relationship with the individual as well. Next slide, please. Certainly, when it comes to the provision of those take-home doses of medication, we recognize from the COVID-19 pandemic that there is safety to this. The incidence of harm or diversion did not increase during COVID-19, and the flexibility to take these medications home. So in the first 14 days of treatment, the take-home supply is limited to 7 days. From day 15 to 31, there's 14 days. And after 31 days of treatment, the take-home supply is capped to 28 days. Decisions around the number of days to provide within each of those intervals rests with the treating practitioner. It's based on the clinical decision environment, and it's based on the practitioner's understanding and discussion with the patient and their ability to manage safely in their home environment. Certainly, decisions around take-homes consistent with all chronic medical conditions should be documented clearly in the patient's clinical record. Next slide, please. When it comes to physical and behavioral health assessment services, there is a requirement for periodic assessment. And certainly this is really important because it includes a requirement of screening for imminent risk of harm to self or others. We recognize the potential for co-occurring disorders, and this should be assessed within the parameters of this examination, and appropriate planning and treatment interventions be designed. Certainly, we do receive a lot of questions around random drug testing as well. And there remains a requirement for no fewer than 8 random drug tests per year per patient. And we do highlight, though, that these drug tests should not be punitive in nature. They should be part of the clinical engagement with the individual and help guide treatment decisions in an open and transparent manner. Certainly, the random drug tests are those that have to have received FDA marketing authorization. And this is important because it imparts an element of reliability, safety, and variability. But that requirement for the FDA marketing authorization shouldn't preclude distribution of any harm reduction services related to testing an individual's own drug supply. Next slide, please. Certainly within the rule itself, there are call-outs for special services for particular populations. For pregnant patients, it's really important to prioritize admission for pregnant patients with opioid use disorder. This includes consideration of split dosing, which is discussed within the context of the final rule and defined. And prenatal care and other sex-specific services must be or shall be provided and documented either by the OTP or through referral networks. And this represents a really important opportunity to ensure the safety of the pregnant person and their infant as well. There's also a need to promote elimination of hepatitis C and other infectious diseases. And so counseling on prevention of exposure and transmission of HIV, viral hepatitis, and STIs is highlighted in the rule and represents a really important primary intervention that can occur within OTPs. For any treatments or ongoing services that are required, this should be provided directly through the OTP or through referral. And certainly this is applicable to those who receive positive test results for any of the conditions listed, either through the initial or periodic medical exam. And with that, I'll now hand it over to Dr. Juliana.
Thank you, Rob. And greetings, everyone. Very happy to see all of you here. This is a remarkable group, and we appreciate everything that you're doing on behalf of the patients. I will go a little bit quickly because I want to allow as much time as possible for your questions, which we have been noting as we go along. Dr. Olson spoke about harm reduction. We also weaved in recovery-oriented systems of care. I won't go into this in depth. The keys are here. I will make a plug for our Office of Recovery Services, which has been publishing a large number of documents that can support the concepts of recovery-oriented care, and also for our peer our colleagues in peer services and promoting them, and the use of peer services in OTP related care. Next. There you go. In terms of the revisions to the regulations, the requirement, thank you, the requirement that OTPs continue to provide make available comprehensive care, that remains. There's nothing different in this part of the content except for some of the language changes of treatment, changing the treatment plan to care plan, specifically to focus more on patient-centered care and to change the sound of it to being something that's being done to a person to being something that is done with the person. The plans should include the patient's goals and what is meaningful to them in the context of the information they receive from their practitioner and counselors, and mutually agreed upon goals and actions that are entered into the plans. Next. We do expect the integration of harm reduction education and recovery-oriented counseling is necessary and mutually agreed upon, so that the purpose of this is to assure that the person is met where they are and that there is an extended environment of care for the person. Recovery is all about relationships. And so we want to make sure that those are available and accessible in and as it should be. That does not detract from the role of the counselors, that there should be a program counselor qualified by education and training or experience to engage with the person, to work on a care plan, and to monitor, support, and update their progress. We have there are some of the revisions to collaborating with community-based resources. There was some language in the prior version that was a little bit more requiring that full memorandums of understanding and agreements be in there. We still expect the services to be revised, available within the community and for people to be aware of them, and to use the community-based resources, local available services to support the needs of the patient that the program might not be able to meet or might not have that particular area of expertise. Next. So there are 2 slides on interim treatment, but it is one of the smaller parts of the whole set of revisions. So we continued interim treatment. This was originally developed to address waiting lists, especially in the late 80s with people coming out of jail and prisons and no room, and when HIV was active and there weren't any treatments for it. So we have, with the revisions to Part 8, we extended the length of interim treatment from 120 days to 180 days to address, as part of the addressing access to care and workforce shortages across the country. We recognize that there are some impediments to being able to provide care in the way it's otherwise intended. During interim treatment services, the concept of formal counseling and other services, that remains, that it is not mandatory that those are provided, but information should be available. What is different also, that's probably on the next slide, is that there is a requirement to have a set plan. Oh, thank you. To have a set plan by day 120 for continuing treatment beyond 180 days. So by day 120 is to raise it as to bring attention to it, so that it gives 2 months to make plans. And within that period of time, there should be a plan for the person to receive the rest of the services from which they would benefit. We do require that there be notification to the SOTA when someone enters interim treatment, when they leave, and before they're transferred. And that all needs to be documented. Next. Okay, so these are a lot of changes into how business is done. We are hopeful and look forward to the opportunities that these revisions provide to enabling programs to actually see more patients by not having some come in as frequently as every day. There's room for others to come in as well. Hopefully it will improve retention and care by being more patient-centered and engaging more from a shared decision-making standpoint. It enables us to expand the reach of the OTPs with mobile units and with med units in other services such as jails, and nursing homes, and other local community resources, CCBHCs, primary care settings. And it also builds in the ability to integrate primary care, infectious disease treatment, and more mental health services than before. Next. Okay. So I'm hoping that some of your questions might be answered by this. We are revising the opioid treatment guidelines. We had 2 expert panel meetings in the summer. Oh, no, I'm sorry. It was in November and October. And those are in process now. We expect it to be able to come out to the field for review sometime in June. And then we've had this series of meetings. We will be meeting with we met with the accreditation bodies first to talk about the revisions themselves. And then our next meeting with them is to talk about some of the ways we will need to work together to resolve questions. Like one, I think about, will an accrediting body have to come back again to see that the corrections were made? That will depend on the circumstances and the accreditation standard, but we'll be working with them to get that information together and to get it out to you, so you have very clear answers to that. And then we've already been working with the CDC, the DEA, FDA, and our other federal partners around many aspects of this, and that will continue. Next slide. And that is to turn it back to Mark to thank you all for being with us. And Mark, could we return to you for managing some of the questions that came in?
Certainly. So I think your three overviews were very helpful, and in fact, you've touched on already some of the questions that have been put. And but let's do a few of the questions, which is, do these new regulations change in any way the provider hours in ratio to the number of patients in treatment?
So, yeah, so Patty, I'm happy to take that one, kind
Go
of
ahead.
start that one. So there, right now, in the regulations, there have not been, even in the prior regulations and in the current regulations, there's nothing that, that we set at the federal level in terms of our requirements, ratios of, counselors to clients, physicians to clients. Those are sometimes set by states, or they're set by also other like payers, etc. So I think that the key to many of those questions also is that if it's not in the regulation, if you can't find it in the regulation, it probably means that it is either that's coming from somewhere else. So it could be state, it could be the payer. And so, I think that those are the types of questions that, it may be that whatever situation kind of, and I've heard of many other questions kind of in other fora as well, that around, counseling requirements. So for example, what happens if you, now that we have kind of decoupled them, if there are counseling requirements, that those could be coming from other places. And so I think it really is important for people to also understand what their state regulations are, as well as what perhaps is kind of in whatever is coming from the payers at this point.
And to Dr. Olson's point, keep in mind that what these federal regulations do is provide not only requirements, but guidance, and the issue of realignment or new alignment, as the case may be, with state regulatory agencies, accrediting bodies, third-party payers are all intersected. They're interwoven. So while this is a very complex undertaking, what you have at least before you is guidance and standards about how you should proceed. I'll also say, from an editorial standpoint, it also gives the OTPs an opportunity to reframe how they provide care to our patients. This is a very important component, and it cannot be understated enough, because the issue here is increasing clinical decision-making within the program environment and also the delivery of compassionate care. I think the way regulations have been promulgated or interpreted over the course of many years, starting with the FDA oversight of 1974, may have contributed inadvertently to some punitive decision-making at the program level. This is an opportunity to, as Dr. Olson and her associates have said, make a cultural change. And cultural changes, frankly, take a long time. But the point is, you have to have a beginning standpoint for cultural change. You can't arrive one morning and say, I think we need to do something here. You have to have a plan. Next question is interesting because this already come up. It's from a clinic operations perspective. A number of programs are closed on Sundays and holidays. So the question here to you is, so do these regulations give OTPs flexibility in closing their operations more often during the course of a week? Some programs, I understand, are closing already on weekends, Saturday and Sundays. So the question for you guys is how programs should interpret the regulations in this particular category.
How do you want to take this one?
So in terms of closing clinics, there are, Mark specifically, it was a very wide.
Well, I think the question here is, can OTPs and given the flexibilities of extended take-home medication, and given individual program assessment, does the program then have the opportunity to consider closing operations either for weekends, Saturday and Sunday, or during the week?
Yeah. So
Sure.
Yeah. So I will say that I think that that my initial kind of response is that the decision for take-home doses is based on an individual patient decision. And so, that there may be many patients who absolutely, again, going back to kind of that clinical decision making, right, where the practitioners working in the OTP may reach that decision that, yes, the risk benefit comes down to the therapeutic benefit of providing, Saturday and Sunday take homes. Just kind of talking about that. Or even take homes kind of like during the week, that actually then outweighs the risks. So I think part of what we're really kind of trying to move away from is we're trying to move away from blanket decisions and blanket decision making related to kind of clinical care. Now the regulations do say that the clinic can be closed one day during the week and then any federal holidays, right? So it could be that there are, you can imagine kind of many different federal holidays where, the clinic would be closed, on those days and on consecutive days. I think the other piece is that there may be circumstances in which there are reasons for, really being able to, like, if there are nursing shortages or workforce shortages, or, I think. But again, it kind of goes back to some of that clinical judgment. And if there is a handful, let's say there's a handful of patients, right, that, really the practitioners feel where and based on that shared decision making and kind of in the clinical judgment of that individual practitioner, that there's a handful of patients who, like, we really, it is going to be really risky to give them, let's say, 3 days of consecutive take homes, that then there are other alternatives to, you partner with another OTP if there's one kind of in the. So I think what it does is, and this also kind of goes to some of the counseling questions that have come up, is that it does put more of the onus on the OTP to really figure out how do we actually kind of be creative in engaging with individuals in, thinking about how do we individualize kind of care? What does each individual patient need at the given time? It changes over time. How do we then kind of, do that? What else can we do to really, but it puts the onus back on the OTP as opposed to kind of saying, I think as Mark, as you mentioned, that like, oh, there's something that the patient isn't doing right, or the patient's not, compliant, or there's something kind of wrong with that individual, that they're not now kind of meeting up to the standards or the expectations that kind of we have and we as healthcare professionals have set for them. And I say that also just, having spent 10 years as the medical director for an opioid treatment program in Baltimore City, and having had experience in a number of different OTPs, because, there certainly are places where there are models of how, programs have really been able to do that, and where people then actually come and ask for additional care. They ask for services. And there's some studies that really show that kind of that type of engagement and that type of kind of patient-centered care in OTPs is just as effective and more effective in some cases than, really having kind of a really rigid one-size-fits-all. So I guess it's a long answer to a short question, perhaps, but I just wanted to take the opportunity to really kind of have it come back to this overarching culture change and kind of these changes that changing from kind of what has been a very rule-based or interpreted as a very rule-based kind of model to now one of really using kind of that clinical judgment and that multidisciplinary team in those ways. That I know that that's not easy, but that's kind of what we're really talking about and kind of the vision of.
And to interpret, before I put the last question, OTPs now have a different opportunity in terms of developing more individualized care. And the idea of tectonic change that applies to all concurrently runs counter to the therapeutic view behind the regulations themselves. So you're basically responding to the individual needs of the patient. And while it's true there are some general assumptions about treating opioid use disorder, the individuals are quite distinct. And I learned that in my 18 years at an OTP, and you have to respond to that. So last question is, and by the way, I'll just say to the audience that you can continue to submit your questions to us, and we will absolutely send them to our colleagues at SAMHSA because they are interested in understanding how the field is responding to this. So here's the question, noting that the first dose has been increased to 30 to 50 milligrams, and I understand what Dr. Ballieu said, depending on the clinician's intake and dealing with the patient, could be even higher. But obviously, all of these things are justified in the patient record. This does not require exception submission. It does require, however, medical charting. That you want to do no matter what, especially around doses. However, here's the question. And it's a matter of when you're increasing the dose on that first day, do you need to split the dose, or simply do you provide the full dose and then noting it in the record? And I know that's an issue of clinical judgment too, but it's reasonable to, this person is asking the obvious sort of question. So what do you think?
No, it's a really good question. I mean, it is confusing because like you said, Mark, we're moving from that rules-based world to a world of clinical judgment and clinical flexibility. And so certainly dosages should be tailored to the patient. How the individual is responding from the point of view of their withdrawal symptoms, what they're telling you, and documenting this. And so it may be that the initial prescription or sort of order is 30 milligrams. The individual still has withdrawal symptoms, and then there's a subsequent order for 20 milligrams. And documenting all this in the notes and documenting observations, documenting rationale, documenting the orders, of course. And then, like we said, if you reach that 50 milligram threshold, that's okay. That's just a regulatory thing. What matters is the individual, and so the individual's response, your response as a clinician, should be reflected in the documentation and the individual's response to treatment. And so I saw another question in the chat around, the FDA insert talks about 30 milligrams being the upper limit, and that's okay. I mean, we federal agencies all have to sort of play catch up here and there, but certainly it's okay to prescribe. We're not saying prescribe 50 milligrams first up. We're saying talk to the individual with clinical judgment, decide what that initial order should be. If they need more, that's okay. Document. So that was a very, very long-winded way of answering the question. But Dr. Olson, I'm sure you have more to say.
Yeah, no, and I was going to say, or if it's less, right? It might be less for an individual. So again, I do think that 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 clinical judgment piece is incredibly important, because you can imagine having someone come in and they're in floored withdrawal, and they've been using, multiple bags of what's probably fentanyl, every single day, and that they used the last time, and now you can see it, and it's visible, then that may be 50 milligrams all at once may be an appropriate dose You know, for someone who's just coming in and they have very little withdrawal and they just use something that morning, it may be that a smaller dose on that that first day is appropriate. So it may be that, you know, someone really doesn't have, they're not using as much, you know, or they've just come out of a correctional center where they weren't getting, you know, medications and they're not on withdrawal, they haven't used anything, that you might need to do a smaller dose. So again, I think that this individualized kind of clinical judgment piece, I know that there are lots of questions in the chat that, you know, also are around these different pieces, and that we will be providing, you know, additional responses to many of those, including in the OTP guideline. I think that, again, this is, you know, this is something that, that when you're talking about kind of a chronic medical condition, that there's not necessarily a, you know, a hard and fast rule for every single person that's going to apply to every single person. So I also think that this is going to be an opportunity to really talk with, you know, peers, reach out to. SAMHSA supports something called the Provider Clinical Support System, medications for opioid use disorder. There are mentorships and additional resources kind of through that, and we'll be continuing to provide some of that over the course of the next many months and beyond, even beyond October 2nd. So so appreciate everyone's questions and everyone's interest, and really helping to better understand exactly how we can see this vision come to light and reality for people.
Well, as you've said, this is a beginning. It's a major change. For what it's worth, and I know people get anxious about change, it's a positive change. And it means better engagement with our patients. And I am grateful for SAMHSA's leadership, and certainly these three, who I have tremendous respect for. And this will just continue. We'll continue a broad discussion during our approaching conference in 2 months. That will happen. And beyond that. So, you know, there's a partnership here that we're outside of the realm of where we started in 1974. And I remember as a very young counselor in 1974, talking to the first FDA inspector who showed up at the program in New York. And he said to me, hey, you know, I normally inspect meatpacking houses. I said, well, this is definitely not a meatpacking house. So, you know, I'm going to help you out with this to the extent that can be done. So for our viewers, thank you for being here, such a large number, and it does obviously show interest in this work. We're prepared for more clinical flexibilities, which is positive, and it means that, yes, decision-making does switch over to the clinician in an extremely important way, and that's what the regulations really gear up for. So continue to submit your questions. This recording will be available, as was last Wednesday's. And I thank Angelina, my associate, for helping to coordinate this webinar. And we'll look forward to this ongoing discussion. So thank you all, and certainly thank you three for sharing your time and your insights and providing guidance. It's very much accepted in a very good-spirited way. So thanks again. Be well. Enjoy the rest of your afternoon.
Thanks so much.
Thank you.
You're welcome.